Hi, my name is Atif Darwish, professor and consultant of obstetrics and gynecology. All pregnant ladies coming to our clinics ask one question regarding supplementation of vitamin D. Would you prescribe it to me or not? My friend is taking vitamin D. My colleague is taking vitamin D. Why you don't prescribe it to me? I need it as an important item for pregnancy. This is the target of this talk. You know that vitamin D is a fat-soluble steroid and has lipophilic nature. What does it mean in a clinical way? It is a fat-soluble, should be taken with fatty diet. So the patient should not use it, for example, in after dinner, because it should be in a fat diet to be absorbed. This is the first message. The second character is being a slowly released vitamin in the body and half-life of approximately 2 months. This means that it can persist in the body for a long time. So if you give the patient vitamin D, you should know that it will persist for 2 months or something like this, and this may lead to hypervitaminosis D if you give overdose. The character of vitamin D being a corticosteroid, which is different from steroid due to the broken B ring of its structure. And we have two main important types of vitamin D. Vitamin D has 5 types. We are interested in vitamin D2 and vitamin D3 because they are of clinical importance, particularly for reproduction and females. And vitamin D2 is absorbed by intestine and it's less stable than vitamin 3, which is cholecalciferol. And the active form of vitamin D, which is calcitriol, 125 dihydroxy vitamin D is considered as a hormone by many authors. So these are the scientific background of this hormone, this drug, which is given to the pregnant lady. As I told you, we are interested in vitamin D2 and D3 only of the 5 types. What happens for vitamin B? In this simple figure, the vitamin D is photochemically sensitized in the skin. Exposure of the skin to ultraviolet beam leads to formation of up to 90% of vitamin D, which is vitamin D3, due to changing 7-hydroxy cholesterol to cholecalciferol. But to have this skin photosensitivity to and changing into this active vitamin D3, a good part of the skin should be exposed to the sun and for at least 10 to 15 minutes per day. And this is an important issue regarding the women in the Islamic countries who are wearing hijab. So the area of skin exposed to sun is limited. So they may be exposed to vitamin D deficiency despite being in a sunny areas like Middle East or something. The 10% source of vitamin D comes from diet, and this can be from fish, some cod liver oil, some dairy, some mushroom, and others. And these diets, if they are plant origin, they are source of vitamin D2. If they are animal origin, they are source of vitamin D3. But generally, it is just 10% of the sources. So the main source is exposure to sun. What happens for vitamin D3, which is cholecalciferol, is hydroxylation. Why hydroxylation? To be active, because it is biologically inactive. So activation occurs in the liver. This is the first station to have 25 hydroxy vitamin D, which is calcidiol. And this is actually that measurement of in the lab is measuring 25 hydroxy vitamin D, not 125. They are measuring 25 only. And then this 25 hydroxy vitamin D goes to the kidney for renal hydroxylation, 1 hydroxylation, and extrarenal in some body tissues like lungs, colon, prostate, breast, immune system. And this is an extrarenal hydroxylation due to an enzyme which is 1-alpha hydroxylase. We have to know that 1-alpha hydroxylase enzyme on the kidney is stimulated by the parathyroid hormone for the second hydroxylation, which occurs in the kidney. So it is exposed to first hydroxylation liver, second in kidney or extra kidney, and then formation of the active form of vitamin D, which is 125 dihydroxy vitamin D, which is called calcitriol. And this is considered as a hormone in the body. It goes to the main function, which is bone formation and other functions, regulations of immune system, reproductive system, and some other target organs. So the functions of vitamin D include basic functions or classic functions: bone formation, promotes bone formation, promotes bone resorption by stimulation, increasing number and activity of osteoclasts in this intestine, helps calcium absorption, calcium binding protein synthesis, and phosphorus absorption as well. In the kidney, formation of this hormone, which is 125 dihydroxy, vitamin D3, and calcium reabsorption and phosphorus reabsorption in the kidney also from the blood. So these are the basic functions of vitamin D: formation of bone, muscles, nerves, and also in the intestine, it increases biodiversity of microbiome and decrease opportunistic pathogens in the guts. But it has some non-classic functions like stimulation of immune system, immunomodulator, like in insulin secretion control, insulin resistance control. In the placenta has some functions. In the non-pregnant endometrium, ovary, and in testes also had some functions. Also, it is important for neuroregulation by controlling the secretion of hormones because it is similar to steroids, and these hormones come from cholesterol, and vitamin D is an important item. The human cycle of vitamin D shows that it is important in all stages of our life. When the body is gametes, just sperms and ovum, they are in need of vitamin D. When she is pregnant, she is in need of vitamin D. After delivery, the baby needs vitamin D, and adults need vitamin D. And these are stations of the vitamin D functions in the body. As I told you, we measure serum 25 hydroxy vitamin D3, not 125. This is the order to the lab. And you have to know that if the vitamin serum 25 hydroxy vitamin D3 is less than 12 nanogram per milliliter or less than 30 nanomole per liter, this means hypovitaminosis D. But if it is more than 50 nanogram, this is hypervitaminosis D, which is vitamin D poisoning with some symptoms like nausea, vomiting, disturbed digestion, and others. And in between, we have not deficiency, we have insufficiency, which if it is less than 20, it is insufficiency. Between 12 and 20, if it is 20, it is called replete, which is sufficient vitamin D. These are deficient, insufficient, and replete, as I told you. The daily recommended values of vitamin D in the human being, males or females, is variable, but generally for females, whether pregnant or non-pregnant, is around 600 units per day, which is 15 microgram per day in the reproductive age. And 1 microgram equals 4 international units. And the US recommended dietary allowance for most adults is 600 international units of vitamin D per day. Imagine that you will rely on food only. You should have to drink 4 to 5 cups of milk, 45 ounces of yogurt, 100 ounces of Swiss cheese, which is beyond the capacity or the daily food diet of any person. So any person is liable to have vitamin D deficiency. Why? Because this is only 10% of the source of vitamin D, and 90% comes from the exposure to sun. Don't forget that the maximum daily allowance It should be 600, as I told you, up to 1,000. Up to 1,000, this is average. But you don't have to exceed 4,000 per day. This would lead to hypervitaminosis D. What's the value of vitamin D in pregnancy? This is a question of the patient. Why you give me vitamin D? Because this is important for building your bones. It helps absorption of calcium and phosphorus, and it is a major regulator of calcium, phosphorus homeostasis. Okay, this is good for my bone. Or I'm drinking a lot of milk and so I don't need to have vitamin D. No, it is important also for prevention of some risks in the pregnancy. Some high-risk pregnancy can be avoided if you follow vitamin D supplementation or you have sufficient vitamin D in your blood. What are these diseases like preeclampsia, bacterial vaginosis, diabetes mellitus, preterm labor, intratriangular stardation, and abortions? These risks can be decreased by different percentages as proved in many studies, and even decreased cesarean section rate 4 times than patients with vitamin D deficiency. So giving you vitamin D supplementation or advising you to eat good food with enough amount of vitamin D is important to prevent pregnancy, early and late pregnancy complications. Not only the mother, you should know that the fetus also and the infant will have some benefit of vitamin D, like decreased growth restriction, physical deformity, and fracture health risks in the fetal period and infancy, rickets, of course, and hypocalcemic complications, teeth problems, less attention deficit, less hyperactive disorder, less autism, less eczema, less bronchial asthma, and all these diseases have many publications, many studies I don't need to go through, but the vitamin D is considered one of the preventive vitamins of all these stages. So you have to inform your patients that when you have sufficient vitamin D, you will protect your body, bones, and muscles, nerves, and you protect your body, yourself from pregnancy complications, fetus and infancy, and childhood period also is covered. And this figure is published by some authors, interesting. It has some benefits in implantation, infertility, impaired immune tolerability, placental insufficiency, bacterial vaginosis, diabetes, preeclampsia, abortions, term labor, and cesarean section. Regarding the baby, nutrient deprivation, IUGR, altered brain morphology, physical deformity, death, and all these are complications that could be prevented with enough vitamin D in the body. So vitamin D is important. And these are some studies of the importance of vitamin D supplementation to improve or to modify the immune system of the neonate and decrease the risk of childhood fractures. Now the patient will ask you, I have vitamin D deficiency or not? How do you know that I have vitamin D deficiency or not? I have to answer by a clinical assessment of your history and from laboratory, of course. Clinically, the patient may have musculoskeletal pain, lot of pain, muscles and bone, particularly back pain, increased sensitivity to pain, tingling sensation in hands and feet, muscle weakness, waddling gait, history of broken bones, muscle twitches or tremors, muscle spasms, or bowed legs. Also, systematically, the patient may have fatigue, poor sleep quality, and all these musculoskeletal pain and fatigue and poor sleep quality, all these symptoms would affect the quality of life. And many studies found that low quality of life with patients with vitamin D deficiency. So now we come to the crucial point of the lecture, to give or not to give vitamin D. I have to give all patients vitamin D. Why? Because the vitamin D deficiency is incredibly common and affecting roughly 40% of population. No, it may affect up to 57% in UK people and up to 75% of American people in some other studies. So if you imagine that 75% of population have vitamin D deficiency. So giving vitamin D is wise for such a population, particularly in patients with high risk of vitamin D deficiency. As I told you, black skin pigmentation, clothes, hijab and sunscreens, pollution, some seasons like winter season, latitudes, high latitude, smoking, alcohol, drugs, patients with malabsorption syndrome, patients with kidney disease for the hydroxylation and liver disease for the 25 hydroxylation, some genetic mutation, some other health problems, some patients with not eating diet, fatty diet, and so on. So these are risk factors we should consider. If the privilege or the incidence of vitamin D deficiency in the population reaches up to 75 in some populations, and there are some risk factors more in these populations. So we have to give the vitamin D for populations. And the WHO mentioned that in cases of documented deficiency, you should supplement with at least 200 international units per day, according to their recommendations. The important supportive issue regarding giving the patient supplements is that many studies recommend the use of vitamin D in pregnancy, and evidence from vitamin D intervention studies and meta-analyses of large number of studies support vitamin D supplementation during pregnancy to improve maternal, fetal, childhood, and immediate and late offspring's health. Here is a study on 30 trials of more than 7,000 women found that supplementation with vitamin D alone probably reduces the risk of preeclampsia, gestational diabetes, low birth weight, and may reduce the risk of severe postpartum hemorrhage as well. Little or no difference in the risk of having a preterm birth if giving vitamin D, and supplementing pregnant women with vitamin D plus calcium probably reduces the risk of preeclampsia. And here is a recent meta-analysis and randomized controlled trial assessment found that as evaluation of 130 trials with a total of 112,000 patients or 113,000 patients found that low molecular weight heparin, vitamin D supplementation, exercise, calcium, and aspirin would reduce the risk of preeclampsia or pregnancy-induced hypertension. So it has an important role in prevention of some serious pregnancy complications as well. And recommendations of the societies regarding supplementation vary, but generally, as I told you, 600 units per day or 15 microgram as recommended by Royal College of Physicians of Ireland or Academy of Nutrition and Diabetes, but maybe be 10 microgram as recommended by FIGO or NICE, and in Japan, up to 8.5 microgram per day. Don't exceed 100 microgram, which is 4,000 per day among reproductive age and pregnant women because of its potential toxicity. I repeat this sentence every time. Timing of vitamin D, as I told you in the first slide, it should be in the morning with a meal because it's fat soluble. This is the main cause, and not to be forgotten. If you give it at night, she has to take a fatty meal, and this may interfere with sleep and make sleep disturbance. This is the reverse of magnesium. If you give magnesium supplements, you have to give it in the night to have relaxation of the muscles and to help her to sleep. So vitamin D in the morning and magnesium at night. It is recommended that pregnant and breastfeeding women take daily supplements because between September and March, because these are wintry months, because no sun exposure and because vitamin D is only found in a small number of foods, whether naturally occurring or added. As you know, it is 10% of the source, and the amount added to some food products can vary and might be small, and some pregnant women have dark skin and cover their skin like hijab, or other risk factors may exist. That is a recommendation of some societies. This is the support of giving vitamin D. Other team of people say, no, we don't have to give routine vitamin D to pregnant ladies. The first recommendation comes from the WHO in August 2023, as it recommends against protein vitamin D supplementation in pregnancy. And oral vitamin D supplementation is not recommended for all pregnant women to improve maternal and perinatal outcomes, and is not recommended to prevent development of preeclampsia and its complications due to limited evidence currently available to directly assess the benefits and harms of the use of vitamin D in pregnancy for improving maternal and fetal health outcomes, and the use of this intervention during pregnancy as a part of routine is not recommended. These are recommendations of the WHO. And this is a meta-analysis of 76 studies and found that the insufficient evidence to have clinical, what are the clinical criteria of vitamin D deficiency in pregnant women? Insufficient evidence. What is the optimal type or dose regimen route? No insufficient evidence. What is the supplementation with vitamin D in pregnancy likely to be? Is it cost effective or not? No insufficient data. Just modest positive relationship with birth weight and bone mass and serum calcium concentration after supplementation, after adjustment of the potential confounding factors in these 76 studies. So now you are confusing me. Some studies and some evidence support giving vitamin D supplementation, and some evidence is against giving. What to do? You didn't answer the question for the patient. I have to say that vitamin D supplementation is recommended for pregnant women, but should be tailored to an individual circumstances. You should evaluate your patient, evaluate the diet of your patient, the pattern of life of your patient, smoker or not, living in high altitude or not, age of the patient, has malabsorption syndrome, has kidney disease, liver disease, and other risk factors or not. If you evaluate your patient properly during clinical assessment, history, and examination, you can reach to the group that who are in need of supplementation, and you can exclude patients with good absorption, with good diet, and with good sun exposure. So these can be excluded from your patients. This is a simple answer, because differentiation or tailoring the decision is dependent on the patient, not on your personal preference. Okay, the important question comes also from the patients and from other doctors. Should we order for vitamin D screening test? As I told you, we test for 25-hydroxyvitamin D. The recommendation of the ECOG that there is insufficient evidence to support recommendation for routine screening of all pregnant ladies. Why? Because there's an expensive test. It costs around $200 or equivalent in other countries. So it is an expensive test. How to make an expensive test a routine screening? Screening should be cheap, easy, available, and test. This is not cheap, not easy, not available test. So it is not a recommended test for routine for all millions of pregnant ladies. So when to request? If you suspect clinically that the patient has hypovitaminosis D due to risk factors, due to some problems as already mentioned. On those groups, you can order for vitamin D testing 25th hydroxyvitamin D, as I told you. The international units giving to the patient 600 units, international unit, but you can reach up to 1,000, up to 2,000 if you need. Never exceed 4,000 per day. Avoid excessive vitamin D due to vitamin D poison sequelae, which include nausea, vomiting, weakness, disturbed digestion, and increased blood and tissue calcium and hypercalcemia with its sequelae. As vitamin D is a fat soluble, I told you this before, and may accumulate in the body tissues, leading to toxicity. Thank you so much.